We're going to get started. So thank you all for coming to the sustainability session. I'd like to start by first recognizing our sponsor, Kerecis. Kerecis is one of our business partners, and they have a very strong focus on sustainability, and they were happy to sponsor this session. So we want to give a round of applause to Kerecis. Thank you. Thank you, Jim. Right, I think you're for a treat today for a great presentation from Dr. Jonathan Slutzman. He is an environmental engineer and emergency physician. He is the director of the Center for the Environment and Health and the medical director for environmental sustainability at the Massachusetts General Hospital, as well as a practicing attending emergency physician at MGH. Prior to a career in medicine, Dr. Slutzman was a consulting environmental engineer completing projects in a variety of areas within environmental health and safety assessment. Starting the line between engineering and medicine, his mission is to improve the environmental sustainability of healthcare delivery, aiming to reduce the environmental costs of healthcare. His academic focus is measurement of environmental impacts in healthcare, particularly using life cycle assessment. He is a founding member and chair of the Mass General Brigham Clinician Sustainability Group, a past chair of the Society for Academic Emergency Medicine, Climate Change, and Health Interest Group, on the advisory committee of the Healthcare Without Harm Physician Network, a founding member of the MGH Executive Sustainability Committee, and a founding member of the Mass General Brigham Climate and Sustainability Leadership Committee. Please welcome Dr. Slutzman. Thank you very much.
Thank you, Dwayne, and thank you so much for inviting me to come down and be with you today. As a little bit of a preface and warning, as Dwayne said, I am a practicing emergency physician. In fact, I practiced until about 7:30 this morning, having worked last night, and then driven down here. So a little bit of the filter is off. There's no telling what is going to come out of my mouth. So now might be a good time if you really have those questions that you want to know the right answer to. It's a good chance. So an apology in advance if I misspeak. I will do my best to keep the brain working at as close to its top condition as possible, recognizing that I am still just a lowly emergency physician. So as Dwayne said, I do a lot having to do with environmental sustainability in Boston, in healthcare, particularly for Mass General Hospital and Mass General Brigham as a whole. And what I'm going to talk with you guys about today is where supply chain fits in and how we in the healthcare industry, as the healthcare deliverers, need you in the supply chain to partner with us in order for us to provide environmentally responsible, climate-smart healthcare. So the first question you might ask is, why do I, as a physician, or why should Mass General, as a healthcare organization, care at all about environmental sustainability anyway? I mean, we're in the business of providing healthcare. We're in the business of keeping our patients and our communities healthy and treating them when they fall ill, and fighting disease and death at every turn. Well, we all know that cardiovascular disease is a huge killer in the United States, and we put a lot of resources into it. We know that cancer is, we know that lung disease is. What if I told you that air pollution fits right there? And that's just the death rate from air pollution. That doesn't include climate pollution, it doesn't include water pollution or soil pollution or any other routes of exposure to pollutants in the natural environment. Our best estimate is about 7 million people die a year because of air pollution. Well, if I'm putting a lot of resources and effort into reducing the death rates from cancer and from lung disease, chronic lung disease, then shouldn't I also care about pollution and trying to prevent those deaths from a public health perspective, right? That's my mission. And unfortunately, healthcare is not succeeding there. We are, as an industry, responsible for about 5% of total global greenhouse gas emissions. It doesn't sound like a very big number, but 5% when you're talking about all of the industries and all of the countries on Earth, healthcare is 5%. If healthcare itself were its own country, it would be the 5th largest emitter on the planet. Lest you think that we aren't great and exceptional here in the United States, We are the number one source of healthcare pollution in the world when you compare healthcare services and industries in other countries. And the US healthcare system would be the 13th largest emitter in the world. That's more greenhouse gas emissions per year than the United Kingdom as a whole. So we're more than most other countries. And that's having negative impacts on our patients. Now here we get to where the healthcare supply chain and GPOs fit in. I took, and Dwayne saw this before, but I took the mission statements, publicly stated mission statements of all of the GPOs that are members of HGPI, of the Healthcare Group Purchasing Industry Initiative, and figured out which words come up the most often. And what you see the biggest there are words like healthcare and health and care. Those are the biggest ones. So our missions match the hospital's missions for the most part, pretty closely. That our primary mission is to provide care to our patients, to our communities, and to keep people healthy as best as possible. Which brings me to this number, 125,000. If I told you that there was something that we collectively in healthcare were doing that killed 125,000 people a year, I hope you would say, what is that and can we stop doing it? In 1999, the Institute of Medicine, now the National Academy of Medicine, issued a landmark report called To Err is Human, quantifying the effects of medical errors on our population. And they estimated that between 48,000 and 95,000 people in the United States die annually because of medical errors. And I'm going to tell you that climate change pollutants from healthcare in the United States kill approximately 125,000 people a year. We see at hospitals around the country vice presidents of quality and safety, chairs of quality and safety committees. The Joint Commission has books and books of standards to improve the quality and the safety of the care we provide. For good reason. I would like to provide safe and high-quality care to my patients. But I question how many of our facilities have VPs for sustainability or medical directors for sustainability. And I can tell you, in North America, there are about 21 of us. How many congressional hearings have there been on medical errors and safety in healthcare? The answer is dozens. Many, many dozens. How many congressional hearings have there been looking at resilience and environmental sustainability in healthcare? The answer is one, and it was approximately a year ago. So we don't have nearly the same attention while the impact on our patients and our communities is comparable. I don't want to say it's exactly the same. I don't want to say one is necessarily more than the other, but at least they're on the same order of magnitude. They're in the same ballpark. So I hope that I've made a case that we should care about environmental sustainability and about the pollution that we generate that has downstream effects on our patients. It makes them sick and kills them. I'll add in that the patients and communities that it hurts and kills the most are the ones who are least responsible for the problem and are the least capable of avoiding the impact. So think of those who are of the lowest socioeconomic status, those who are the poorest, those who live in the worst housing, in the worst neighborhoods, right next to the highways and the factories and the power plants. The folks like you and me, honestly, when the climate really tips over and there are huge disasters, for the most part, those of us in this room are gonna be okay. We have homes, I hope. We have the means to keep them safe. We have the means to acquire food and do the things that we need to keep ourselves and our families safe. But the folks who I treat, the folks who I see night in and night out in the emergency department, they're the ones who are going to suffer the most, and they don't deserve it. So we have a moral imperative to do the right thing here. Now raise your hand if you've seen this chart or anything that remotely resembles it. Okay, great. This gives me an opportunity to teach something. I love it. We have to get a little bit into the weeds, but only the shallow weeds, the short weeds of greenhouse gas accounting, so that later I can show you what we're doing and why it matters. The Greenhouse Gas Protocol is the international agreement, way of measuring and reporting greenhouse gas emissions from any reporting entity, whether that be my hospital, my health system, the country as a whole, a manufacturer, anybody, any reporting entity. And it divides greenhouse gas pollutants into 3 different scopes, 1, 2, and 3. And I'm going to use our homes as an example here because it makes it a little bit easier to think of than a giant hospital. In your home, specifically my home, I have a heating system. It runs on methane natural gas from a pipe in the ground and gets burned in the furnace, and carbon dioxide and other pollutants from that go outside of my house into the air. That burning of that fossil fuel that generates greenhouse gases is a Scope 1 emission, direct emissions from a reporting entity. Another example would be I drove my car down here. I currently own my last internal combustion engine car. I expect to replace it at some point in the not too distant future with a battery electric car. That car burns fuel, it releases pollutants, including carbon dioxide and other things, and I drove it down here from Boston to Newport this morning. The emissions from that tailpipe are my Scope 1 emissions, direct pollution from my reporting entity. Hospitals have a couple of added interesting ones. Our anesthetic gases are greenhouse gases, so even though we're not deriving them, we're not burning a fossil fuel to release sevoflurane, the sevoflurane itself is a greenhouse gas, and it goes up the stack. Approximately 99% of what we deliver to patients ultimately gets breathed out and into the atmosphere. So that's a Scope 1 emission. Scope 2 emissions are indirect emissions from purchased energy. So I buy electricity for my house. That electricity has to be produced somewhere, somehow. The pollution from that production is my responsibility. That's my Scope 2 emission. At Mass General Hospital, we heat the hospital almost exclusively with steam that comes from a cogeneration electric power plant across the river in Cambridge. We actually built the pipe that brings the steam across to our facility because they were going to just send that steam up into the sky, and we said, why waste that steam? That's very useful. We can use it. So the pollution from generating that steam are Mass General's Scope 2 emissions. Scope 3 is everything else. It's indirect emissions from patients coming to us and going home, from our staff coming to us and going home, from all of the equipment we buy, from the buildings we build, from the waste that we throw away when that decays in a landfill. Those are all our Scope 3 emissions. Clear as mud, right? Everybody gets it. If we took a quiz later, everybody would do great. That's fine. You'll get there. So just keep in mind Scope 1, direct emissions, Scope 2, indirect energy, Scope 3, everything else. This is a pie chart from the UK National Health Service. They are the leaders among healthcare providers on the planet in providing sustainable healthcare and transitioning to a greenhouse gas-free future. They've made the most progress. They've done the most tracking and measurement. So they looked at their footprint, and this is what they got. And the important part that I want you to pick up on is that 62% of it comes from you. It's all of the stuff that they have to buy to provide their care. It's medicines, it's medical equipment, it's supply chain, other things like office supplies. Anything that you need to buy to run your hospital, that's 62% in the UK. I hate to tell you this, but that's actually at the low end if you look at other health systems. And the reason it's at the low end is because their facilities, their buildings are actually very old and fairly inefficient. So their Scope 1 and 2 are higher than they are for, say, MGH. But we'll get to that. So 62% comes from all of you guys who are providing what we at the hospital are asking you to do. So that's where the partnership comes in. We cannot reduce our emissions more than, or at least the UK NHS can't reduce their emissions more than 38% without engaging with the supply chain. And 38% isn't going to cut it. What does Mass General Brigham look like? And I wish I could show you 2023, but honestly, we finished the numbers 2 weeks ago, and I haven't made the chart yet. But they're not super duper different than 2022. So we'll use the 2022 chart. And what you'll see is our scope 1 and 2. So the scope 1 is the black one over here, and scope 2 are these two relatively small blue ones. And scope 3 is everything else, all this green. So 82% for Mass General Brigham is scope 3. And of that, most is purchased goods and services and capital goods, so stuff we buy. There's another big chunk that's employee commuting and patient travel. So these two numbers are those. So we need to do better there. But really, once you take out travel, everything else is stuff we buy. And that's you guys. The reason that our number 1 and 2 are so small, for number 2, our electricity number is tiny compared to hospitals. Now keep in mind, this is not just Mass General Hospital. This is all of Mass General Brigham, $16 billion operation at the time, with 13 acute care hospitals. We purchase 80% of our electricity as renewable, predominantly wind with some hydroelectric. The only electricity that we purchase that is not renewable are purchases that we are legally required to make. So we have a facility in Danvers, Mass, where we are required to purchase from the Danvers Light and Power Plant. We have a facility in Longwood. It's kind of a big one that has a cogeneration plant right next to it, and we are stuck in a long-term contract with that plant to buy the electricity from there. We are working actively to try and get out of that contract because we really want that power to be coming from renewable sources. So that's the small one there. And then the steam is small because of that cogeneration plant across the river. A lot of the emissions from that cogen plant go to electricity and not to the steam. So that's why our scope 2 is so small. We're doing a lot of work there, and we have been for about 20 years. And then our scope 1 is relatively small because we do a lot of retro commissioning and site efficiency work to try and make our facilities as efficient as possible. But again, that still leaves the 80% or so that we need to partner with you guys. And we're not the only ones. So if you've ever heard of Kaiser Permanente or the Cleveland Clinic, or obviously I mentioned the NHS, these are big health systems that have pretty robust, sustainable purchasing programs with standards. So if you want to do more business with them, it's incumbent on you to do the things that they're asking you to do, to be a more competitive supplier, to be able to get their business. And the UK NHS, as the world's leader, you might know that they're setting out some very ambitious targets for their suppliers. And the most important target there is that starting in April of 2028, so about 3.5 years from now, anyone who sells more than £5 million of products to the UK NHS will be required, with very, very few exceptions, to report product-level greenhouse gas emissions, meaning you are to sell this bag of saline, which, if you happen to have a bag of saline to sell, I know some people who want to buy it, so meet me in the parking lot. But if you want to sell them a bag of saline, you're going to need to be able to tell them that the embedded carbon in that, the embedded greenhouse gases from the production of that bag, are 125 grams. I have no idea what the number is. I just made that up because they haven't been reporting it yet. But what that tells you is that data are key. And you have 3.5 years to figure out how to do it, which honestly is long enough. You can do it in that time. It also means that the sooner you do it, the greater a competitive advantage you have over others, because of what I'll tell you in a little bit about how we decide what we want to buy. As the UK NHS leads across the Atlantic the U.S. healthcare industry is making their own commitments. And about a year and a half ago, the U.S. Department of Health and Human Services announced a pledge program where healthcare organizations, predominantly healthcare delivery organizations, but also suppliers and ancillary companies, would be able to sign on to a pledge to achieve net zero carbon emissions by 2050 and 50% in Scope 1 and 2 by 2030. And these numbers are as of a couple of months ago. Oops, wrong button there. Health systems and other care providers, 89. And the bold-faced ones are the ones that are among the 40 largest in the country. So they're well represented. There are a lot of large health systems here that have signed on. The National Academy of Medicine has an action collaborative on decarbonizing the U.S. healthcare sector. We actually just had our quarterly meeting last week, or 2 weeks ago, in Washington, where we are setting out some ambitious targets. And they're not the only ones. So National Academy of Medicine, along with many other leading healthcare group organizations, are pushing forward for more standards. Healthcare isn't the only one, though. So anybody here related to or somehow working with a public company? Medtronic's here. I know you're a public company. There are public companies here. So the SEC is working on what this rule is going to mean, and I haven't looked in recent days or weeks, so I don't have the latest knowledge. But they're basically working towards a rule that's going to require reporting of greenhouse gas emissions from your operations, which means you need to measure them. It's going to require probably Scope 1 and 2 emissions only, which honestly is not that hard. It takes us, we'll say, hundreds of person hours to calculate our greenhouse gas emissions for Mass General Brigham. Of that, Scope 1 and 2 takes about a day for one person. So 1 and 2 is relatively straightforward and easy. It's Scope 3 that's the hard one. So the SEC is going to require Scopes 1 and 2 and will require materially climate-related risks to be disclosed with your mitigations, which gets at the resilience problem. I'm looking at you, all the people who make IV fluids. That doesn't include Scope 3, but does anybody here do business in California? Some of you are lying. Yes, okay, so I do not do business in California, yay for me. But many of you do. California has their own standards that are coming out that will require any companies doing business in California with revenue over $1 billion. What is not clear to me is whether that's $1 billion in California or $1 billion total if you do any business in California. I guess we'll see what that final rule looks like. But it will include Scopes 1, 2, and 3, starting in 2027, where you have to report to an emissions reporting organization. That could be EcoVadis, that could be CDP. We don't know which ones will be included or won't, but it's generally good practice to figure that out, and there will be details coming out from the California Air Resources Board. The U.S. Healthcare Climate Council, of which Mass General Brigham is a founding member, is a group of about 20 healthcare organizations, leading healthcare organizations on climate and sustainability across the United States, who are committed to doing better and bringing the industry along with them. We are creating a climate excellence standard for healthcare suppliers. It will not be a you apply and get this certification. It will be if you meet these standards, you can put this stamp on your stuff and be able to say that you meet it. The interesting question is, will the National Academy of Medicine, as part of their guidelines, say that we as healthcare organizations should be purchasing from suppliers who meet these standards? That's a distinct possibility. Will we as healthcare organizations on the Climate Council and in other organizations say we want that to be a requirement anyway, even if NAM doesn't say it? Will the Joint Commission start including it in their sustainability certification? Will HHS or CMS start requiring it, as we know that CMS is moving forward with their decarbonization program through the TEAM initiative? It only has a few requirements. Suppliers need to commit, measure, disclose, and assure their greenhouse gas emissions, preferably through the SBTI, the Science Based Targets Initiative. Nonprofit organizations are exempt from SBTI. I learned this the hard way when Mass General Brigham tried to set a target, and SBTI said, no, you can't. So if you're a nonprofit, you get a pass, but you can still basically follow the same rules. You have to minimize the use of offsets, publicly have a publicly available plan to reduce your emissions, and incentivize your major vendors to do the same. So not huge requirements to meet the standard. So let's look at the top 20 suppliers to U.S. Healthcare Climate Council members. You notice this chart only goes to 15. It's not because I've been up all night. It's because we sent the survey to the top 20 and only 15 replied. Of those 15, today, 2 would meet the standard. And I'll tell you, when we start issuing RFPs for supplies, we're probably going to like those 2 more than the other 18, giving them a competitive advantage. So there's room for improvement here. Another initiative is CHARM, which is a collaboration with healthcare suppliers and manufacturers, as well as purchasers, meaning the healthcare organizations, to improve emissions and resiliency from the supply chain to healthcare. It's being led by Kaiser and Vizient with additional participants. You see NAM is on there as well, not surprisingly, since they're really moving much more strongly into sustainability work. What's CHARM doing? They're focusing on 4 areas: renewable energy, product innovation, product utilization, and transportation and logistics, encouraging their supply chain partners to make efforts in each of these with guidance on what to do and how. So things like purchasing renewable energy through power purchase agreements, or innovating products with different materials or different packaging, or take-back programs, or in product utilization and clinical engagement, reformulating OR packs and reprocessing single-use devices where feasible. And transportation and logistics, things like optimizing the way that our supplies get sent to us. And that's partially on us because we, geniuses that we are, will say, oh, I have this procedure tomorrow, I need a device tomorrow, instead of saying, I might not know exactly how many bronchoscopies I'm going to do on January 23rd, but I'm willing to bet that I can get it right within 5, because I know what day of the week it is, and I know what season it is, and I know who I have on staff who does them. So maybe I can plan ahead, and then instead of needing equipment to be flown from Ireland or anywhere else around the world, it can be sent by ship, which from an environmental perspective is immensely better, and then still get to me on time. Sustainability in every RFP. We at Mass General Brigham, as well as many of our peer institutions, include sustainability statements in all of our RFPs for supplies and equipment. You don't need to read each individual statement here, but the gist is we ask a number of questions. We are working with some peer organizations to make this easier for you by trying to ask the same questions as everybody else so that we can make it easier for you to answer them. The more data you can provide, the easier these questions become to answer. For example, if you could tell me for each product what the actual climate and other pollutant emissions are, then it doesn't really matter to me what the answers are to every other question. Because by answering that one question, you've told me you have a program, you're committed to measurement, you're willing to report it to me, you're willing to let me compare it to other suppliers. So you've already answered in the affirmative many of the other questions without actually answering them. And I'll tell you right now, in the land of the blind, the one-eyed person is the sovereign. So if you report your product level emissions and nobody else does, I don't really care what the number is. It doesn't matter what the number is if I can't compare it to anybody else. So the fact that you're willing to do it tells me right away that I want to support you. That does not mean that price is not an object. We actually had a case a few years ago where a potential vendor, an actual vendor, we actually buy some of their products, wanted to sell us a couple of different products that we would use in our operating rooms to replace traditional plastic items. And they said, well, it's more sustainable. And I said, let's prove it. So we did a back-of-the-envelope life cycle assessment, not sufficient for a product-level declaration, but sufficient enough for us to make internal decisions. And we could say with reasonable confidence that those products would reduce the climate emissions from that device at our facility over the course of a year by about 45%. And the product would cost 63% more. We are not opposed to spending more for better products. We do it all the time. What we are going to do, though, is we're going to say, well, a 45% reduction in greenhouse gases from that product turns into, it comes out to be about 14 tons of CO2 equivalent per year. And you don't remember the exact number that I showed earlier, but Mass General Brigham in 2022, our emissions were 1.2 million kilograms. Actually, yeah, I think it's 1.2 million kilograms of CO2 equivalent. So 14 tons is just, it doesn't mean very much. And it would have cost a lot of money. It would have been about $250,000 for 14 tons, which is not a good ratio. We said for the same $250,000, we could try and capture all of our anesthetic gas emissions, which would be 3,000 tons. So much better ratio. So we make those decisions. But for a device that we have to buy, if you report these data to us, we will look very, very favorably on it, as will our peer institutions. How we consider them and how we consider those answers, as I said, product emissions are at the top. So if you have some commitments, like you say, we want to reduce our emissions by 50% by 2040 and net zero by 2050, that tells us you've at least thought about it. If you have measured your organizational emissions and are willing to report it, that tells us even more, that you're really measuring something so that you can manage it. If you're looking at factory site emissions, so you can say, well, this product is made at this factory and the total emissions from that one factory are X, we can't tell you what the actual is for that one product, but for the factory as a whole, it's this. Then that's one step up. Then you can get to product line, and then finally product level, which is the best. And if you want to sell to the UK NHS, you've got 3.5 years to get to the top of that pyramid. Data would be nice. These are actual pictures from my pantry. I go to the supermarket, and I decide what my household is going to eat. And I make those decisions based on a whole bunch of factors. Nutritional value, what my children like, what's easy to make, what it costs, a whole bunch of factors. What's available. But I have information to make those decisions, right? I have these nutrition facts that are standardized and they look the same for every kind of food you can get at the supermarket. The numbers are obviously different, the serving sizes are different, the ingredients are different, but at least I have a standardized way of getting those information. Wouldn't it be nice if I could do that for the things that I buy and provide for my patients? This is an ACT label. It's created by My Green Lab, which is a nonprofit organization striving to improve laboratory sustainability. And they created this prototype for different products used in laboratories. But wouldn't it be great if we had a standardized label for things that are used for patients? So that I can say, well, this one's X and this one's Y, and I can compare on price, and I can compare on resilience, and I can compare on pollution. Because again, the pollution is killing people, and that I care about. I'm going to take hopefully no more than 4 minutes to give 2 case examples. These are real cases, one from UCLA and one from Mass General. At UCLA, before COVID pandemic, they looked at their precaution gowns. So the gowns that we wear when we need to go and see a patient who's on contact precautions because of some communicable pathogen. And they had been using disposable gowns, and they said, wait, this isn't very sustainable. Can we go to reusable gowns, like actual fabric that gets put in the wash? The same as the scrubs that I wore last night and saw every single one of my patients that I then put in the laundry, that the hospital does for me, thankfully. And they looked at it and they designed a gown that everybody at their institution was happy with. And they priced it out, and they bought a whole bunch of them, and they partnered with a laundry to be able to launder them. And a few things happened. 1, their pollution went down from the gowns. 2, they saved about $1 million a year. 3, when COVID hit, they didn't run out of gowns. My institution, in around 2017, 2016, somewhere around there, we had been using cloth, reusable precaution gowns. People weren't wearing them properly, so our compliance and infection control teams came in and said, this is not okay, you have to wear them properly, and if you're not going to wear them properly, we have to replace them. So they replaced them with disposable gowns that are easier to wear properly, mostly because it's impossible to wear them wrong. And they get thrown away. And then COVID hit, and the price of them went up by a few orders of magnitude. And our trash went up by a lot. And we had trouble sourcing them because everybody on the planet wanted them at the same time. Thankfully, we never went to the garbage bags that we saw in photos from New York City. But we did end up using 4 different suppliers, I think, over the course of a 1 or 2 year period just to get enough gowns for our hospital. Spaulding Rehabilitation Hospital, which is part of Mass General Brigham, still used durable, reusable gowns. They had no COVID problem. So you can make sustainable choices that save money and are more resilient. Now let's look at bronchoscopes. 2-ish years ago now, I got an email from our executive director of perioperative services at Mass General saying, hey, I got a request from the chair of thoracic surgery. She wants to get these disposable bronchoscopes for the OR. And I saw the request and I thought, that doesn't sound very sustainable. I'm going to ask Slutzman. So he sends me this email and he says, what do you think? And I said, I think this is a bad idea. I think we're using reusable, durable bronchoscopes. We have been for decades, and I use them in the emergency department. And why don't we just keep using them? It led to a whole bunch of discussion, a few meetings with the supplier who wanted to sell them to us, at which point we learned that there was some greenwashing going on. They had a lovely slide as part of their presentation saying that the bronchoscopes, the disposable bronchoscopes, get recycled. That was the title of the slide. And I just asked, okay, tell me about the recycling. And they said, well, we collect the bronchoscopes, we disassemble them, we separate the plastic from the metal gets sent to a recycler, and the plastic gets sent to a waste-to-energy recovery facility. I said, okay, I have 2 questions. 1, what is the fraction of the metal to the plastic? And they said, well, you'll get a report each month saying how much. I said, perhaps I wasn't clear in my question. You make this device. You know exactly what's in it. How much of it is plastic, how much of it is metal? And they said, 30% is metal, 70% is plastic. I said, okay, great. And when you say waste to energy recovery facility, do you mean you incinerate it? And they said, well, we recover the energy so it doesn't go to landfill. I said, that's okay. You burn it to generate electricity rather than sending it to a landfill. And they said, yes. I said, okay, so you take the plastic and you burn it, and that's not recycling. You can call it landfill diversion, but you can't call it recycling. And it's 70% of your product. That's not particularly sustainable. So we ended up not bringing those into our OR. We actually ended up removing them from a few of the places where we already had them. So our heart center ICU, which does a lot of bronchoscopies now, does not purchase more disposable bronchoscopes. They are available for rare cases when absolutely needed, but we did not expand their use because we decided it's not the more sustainable choice. Instead, we started looking at, are there better, durable, reusable bronchoscopes, newer ones on the market, that do a better job than the old crummy ones that we have in some parts of the hospital? So what I want us all to think about is how we make decisions. And for decades, healthcare institutions have been making decisions at this intersection between clinical effectiveness and financial cost. And clinical effectiveness includes, does the device work? Does it provide good care? Do we have good outcomes? Is it safe? And then obviously financial cost is what it sounds like. And what we really need to do is think about this smaller intersection where we have resilience and the environmental costs, the pollution, the health harms, as well as the financial cost and the clinical effectiveness, so that we can be living in that center where we're doing better for everybody. And that doesn't mean that we're always going to pick the most sustainable choice or the most resilient choice or the cheapest choice or the clinically best choice. We're going to optimize and deal with competing priorities, but we're going to do it explicitly. And we're going to do it purposefully so that we can protect as many patients as we can all together. Because as I said at the beginning, I can't do this work without all of you to help, since 80-something% of my climate emissions from the hospital are in partnership with you. So I'll take any questions you have. There's a microphone in the middle you can use, or just shout to me. Yeah.
Can you explain that slide again?
Sure. Let's go back to it and try not to go too far. No, that's okay. No apology needed. Oh, there. Yep. Of course, I went too far. Okay. So about a year and a half ago, the Department of Health and Human Services issued a call for healthcare organizations writ large, although originally it was designed for hospitals, clinics, actually healthcare delivery organizations, to commit to reducing their greenhouse gas emissions 50% by 2030 and to net zero by 2050. And once the first cohort signed that, there was a big event at the White House where we kind of patted ourselves on the back and said, yay, aren't we so great? And announced this, and then left it open for additional signatures. So every 6 months or so, I update the slide to see who else has signed on and figure that out. Obviously, the writing gets smaller each time because there's no way I can fit them all. To give an idea, I don't know how many health systems there are in the United States. There are about 5,000 to 6,000 hospitals, but a lot of them are in health systems. And 89 health systems, hospitals, and other providers have signed on. Some of these are pretty big. So for example, US Acute Care Solutions is the largest employer of emergency physicians in the country. UPMC, Providence, Northwell, RWJ Barnabas, Kaiser, Common Spirit, Ascension, Advocate Aurora, and Advent Health are, I think, 11 or 12 of the 40 largest health systems in the country in terms of number of beds. So huge number of beds. And the example that I use in talking about purchasing power is if you have any children in a public school, the textbooks they use are determined by California and Texas. So the school boards in Texas and California basically set the standard for what all of our kids' textbooks say because they are the biggest markets for textbooks. And it turns out that they're somewhere around 10 to 20%. So it takes, at most, 20% of a market to drive it. This is pretty close to 10 to 20% of the US healthcare market, probably. So once you get the Ascensions and the Common Spirits and the Mass General Brighams and the Cleveland Clinics and the Mayo Clinics to come around and say, we care about sustainability, we're going to ask you about it, well, somebody in the market is going to start answering, and they're going to get more of our business. And then the rest of you are going to want to say, hey, we want your business too, and follow along. So I think that's how healthcare supplies is going to become a bit more like the textbook market when it comes to sustainability. Does that answer? Great. Other questions? No questions too silly. Yeah?
Where do the ISO standards fall in relation to the CES stamp and organizations such as CHARM?
Yeah.
Separate entity, or do they include the ISO standards into their protocol?
Good question. Okay. Up to now, CHARM and NAM and the CES standard from the U.S. Healthcare Climate Council don't mention ISO standards. As far as I know, and I usually stay abreast of this, I'm in the community, there aren't any ISO standards specific to sustainability in healthcare yet. There are ISO standards for how to perform a life cycle assessment to determine your, what's that?
Milliscore?
I'm sorry.
Milliscore?
Milliscore I'm not familiar with. But for life cycle assessments, there are pretty strict ISO standards. There are then product category rules. There is a product category rule being proposed right now out of the UK. The UK is member of ISO for pharmaceuticals. So that will give even more prescriptive guidance on how to measure pollutant emissions from pharmaceutical manufacture. There are ISO standards for environmental management systems. There are ISO standards for environmental product declarations, EPDs. So what it takes to be able to market and advertise a product as having certain environmental characteristics, whether that's an emissions number or a superiority statement or something like that. There are ISO standards for that. The ISO standards are voluntary, but I think what you'll find is organizations will start saying, if you're going to do this, you should follow the ISO standard or something similar. I'm leading an effort on setting a standard, a guideline for life cycle assessment studies in healthcare. And one of our lines is it should meet the ISO 14040 standard. Yeah, in the back. Maybe use the microphone, because my hearing is terrible and I've been up for a long time.
Yeah, no problem. Is it on? How jazzed are you guys about sustainability? I mean, this guy's the legend himself. Thank you, Jonathan. My name's Jamie. I work with Green Health Approved. I am associated with Healthcare Without Harm, and I can speak to some of the stuff about the CES, so please find me if you have questions. And I hope that kind of gears you up for tomorrow's sustainability track. We, at Green Health Approved, bring all of this great work that Jonathan has been talking about to the product level. So I know that that's what a lot of people are interested in, and I just want to say thank you, Jonathan. I'm excited to chat with you after this, but this was incredibly helpful to understand the whole landscape of sustainability within healthcare. So hope to meet some of you later today and tomorrow.
Great. Thank you. I think I now know that I am standing between you and lunch.
I just have one last question. So, as you know, a lot of hospitals are struggling financially, either with a low or negative profit margin.
Uh-huh.
And sustainability may not be a high priority for them.
Yeah.
How do you balance sustainability with financial viability?
Yeah. Good question. Here's the secret about sustainability. Until you are very far down a sustainability journey, nearly everything you can do that improves your environmental performance will also improve your financial performance. In almost all cases, early in your sustainability journey, the sustainable choice, the more sustainable choice, is also a more financially viable choice. They all have positive ROIs. They might not have 1 month or 2 month payback periods. So there might be a need for some capital investment up front. Thankfully, the Inflation Reduction Act has funding that is very generous for many sustainability infrastructure interventions. Things like building retrofitting and changing heating sources and electric vehicles, where basically the IRS will give you free money even if you're a nonprofit entity through direct pay. So there is money available for some things. Other things, there are opportunities to partner with third parties, basically to invest, and they get some financial return. You get to be able to do the thing and get less of a financial return, but at least be able to do it. So that's another opportunity. Green bonds have pretty good, attractive, they're attractive to lenders. But really, everything that we've done to this point, and we've been doing sustainability work for a couple decades, has essentially saved us money. It might not save us money this fiscal year, but it will. So we entered into a lot of power purchase agreements 15 years ago, not because it was sustainable, not because it was environmentally better. I don't want people to get the wrong impression there. We actually did it because it reduced our electricity prices by a lot and locked them in for a long time. And it turns out that it reduced our emissions, so we're happy about it. But that's the case, right? Like UCLA switching to durable gowns, $1 million a year. And that actually, the payback period is within the same fiscal year. We modeled it for our institution, and we were going to come out ahead in like month 4.
Give me a round of applause for Dr. Slutzman.